So hyponatremia cannot lead to brain stroke. However, the rapid correction of hyponatremia, if you're giving 3% saline to a patient who has hyponatremia and more than 8 to 12 millimoles per 24-hour correction can cause quick osmotic changes in their brain, which can lead to a condition which affects their pons. I'm not remembering the name of the condition, which is easily seen on an MRI after a few days. Yeah, pontine myelinosis. Thank you so much for that. So that is something which can be caused due to very quick correction of your hyponatremia. So you need to be very, very meticulous when you correct your dyselectrolemias, especially with the sodium. So it is very commonly seen if you're being very, very aggressive in correcting your hyponatremia. On the other hand, if a person has stroke and they are dehydrated, they haven't been able to take orally well, then that can lead to hyponatremia, but not vice versa. I think we can go ahead.
Yes, doctor, please. Thank you.
So how do we manage these kind of patients? If there is type 2 respiratory failure, we need to have a look at their ABG, which is, of course, going to tell you their CO2 and oxygen levels, their pH levels. It is absolutely important that their pH is actually kept higher than 7.25. 7.25 is the pH wherein your bodily mechanisms and chemical reactions are still taking place at some kind of optimal level. However, not to the 100% tune of optimal level, but still they are doing their function. But if it is less than 7.25, the bodily mechanisms and chemical reactions go haywire. So that is the reason we always aim for this kind of pH in your ICU patients. The normal level is between 7.35 to 45. The normal levels of CO2 we consider is 35 to 45. On the other hand, the bicarb levels, which are normal, is 18 to 24. On an oxygen, which should be more than, the PO2 level should be more than 80. That is the normal ABG value. We have to do a chest X-ray in these patients also to rule out any parenchymal causes of their respiratory failure. These patients, as I told you, could be having a pneumonia sitting in there causing the hyponatremia, which needs to be treated, of course, and your TLC would not be increased in case of any atypical pneumonias or viral pneumonias. CT chest, if your chest X-ray is showing some kind of infiltrate, you're not able to find out what is going on there, you can get a CT chest done. PFT, especially if your patient has been a smoker, to rule out any obstructive airway causes, and serum bicarb, as I already told you. Sleep study needs to be done for titration of PAP therapy, which is positive airway pressure, and seeing any the severity of OSA in these patients. The weight loss, correction of metabolic parameters is absolutely paramount, as somebody pointed out, DKA. So if a person is morbidly obese, we do need to rule out diabetes, hypertension, as well as the dyslipidemias, which are very, very commonly seen along with these kind of problems in a patient. So initially, these patients could respond to CPAP therapy because the major mechanism is hypoventilation, which is occurring. If you're giving a constant pressure during the nighttime, half of their problem is solved. They do not have frequent arousals, desaturations during the night. They take a good night's sleep. They get better with their tiredness levels during the day. When they are no more tired, they will be able to engage in their exercise regimes in a better manner. And they will tell you, now we are able to do exercise and could collaborate to lose some kind of weight. However, if these patients are not getting better on PAP therapy, which can be revisited in a period of 3 to 6 months, you could also give them bi-level therapy. So bi-level therapy means that there is an IPAP, which is the inspiratory pressure, and there is an EPAP, which is the expiratory pressure, which is set on a machine which is known as bi-level positive airway pressure machine. So this is something which we can discuss further on when we discuss further slides. Bariatric surgery, of course, if your patient is having certain criteria, which means they are morbidly obese, they have metabolic derangements, they have central obesity, they're unable to control their diabetes despite being on optimal therapy, Bariatric surgery is something which can lead to more than 10 to 20% of their body weight in a rapid manner, which is actually required to get off these metabolic derangements very, very quickly as compared to conventional methods of weight loss. However, you should be asking the patient directly if they have already tried all the conventional methods of weight loss and they have not helped. In refractory cases, sometimes we do get patients who are not getting better, even with bi-level therapy, they could be requiring tracheostomy. So in all, we have seen that it is the multimodal therapy which helps in the betterment of your patients. During acute exacerbations of chronic respiratory failure, you need to take care of their comorbid conditions. For example, in this case, we had hyponatremia, which needed to be corrected with the correction of dehydration. And also their nocturnal PAP therapy needs to be optimized. You have to make sure they are using their nocturnal PAP therapy for a minimum period of 6 to 8 hours, which is when it is going to be helpful, because REM sleep is the one where maximum of the desaturations are happening. And REM sleep doesn't come in the initial parts of sleep. It comes in the later half of the sleep, which is when the patients usually take off their machine saying that बहुत जोर से हवा आती है face पे. So that is something which needs to be reiterated to these patients. You have to tell them कि 4 घंटे लगाने के बाद ये निकालना नहीं है. It has to be continued for minimum of 8 to 10 hours for whole duration of your sleep. Of course, weight loss is seen to be very, very important, and diabetes and other metabolic derangements and comorbidities, including hypertension, needs to be corrected before these patients, due to chronic retention of CO2, go on to develop any kind of pulmonary hypertension. We go on to case number 2. We have a 55-year-old lady who's a diabetic for more than 10 years, presenting with fever, cough, which was mostly dry, along with shortness of breath, which has been present for 3 days only. So before this, the symptoms came in 7 days before. For the past 7 days, patient is suffering from all these symptoms, but the shortness of breath has set in for the last 3 days. On examination, the patient is unable to speak in sentences. The room air SpO2 is 88. She's in clear respiratory distress. You can see the distress on her face, the anxious look. There is audible wheeze and few crepitations at the lung bases. The oxygen inhalation is started for the patient with stabilization along with continuous nebulization for 15 to 20 minutes. We do an ABG along with stabilizing the patient, and it is suggestive of hypoxemic respiratory failure. The ABG is in front of you. The values are 7.50 of pH, 32 of PCO2, 59 of PO2, and a bicarb level of 25. So let's have a small discussion on this case presentation. This is the CT of the same patient which I'm talking about. In between, while they were coming to me, because they had shown 7 days back when she already had cough and fever only with no onset of breathlessness, they got a CT done outside before coming to the hospital. And this is one of the films which is in front of you. This we can discuss the CT findings also.